sir. Clinically, we just label it as that, sir.
Oh,
You do not require FNAC, you do not require ultrasound, sir.
okay. So, should we also go for any autoimmune treatment, like for the selenium, zinc, and all those things?
No, sir, no, sir, no, sir. None of them have shown any benefit in any form of clinical trial, sir.
I have a cousin, my first cousin, incidentally, just otherwise. She's like, around 46 years of age. She's in the US. She has got some autoimmune disease. I do not know honestly what. One of the very interesting things that she's taking is a very high dose of curcumin. In India, I think we don't have curcumin available in the form of, purified this thing. So she's taking almost 4 to 5 gram of
Yes, sir.
curcumin in the
Hmm.
form of capsules on a daily basis. And she said her physician is a Indian doctor there, and he's very convinced that you should take this. And she's lost quite a lot of weight. She's hardly about 40 45 kgs. She used to be almost 65 70 kgs, but she's stable on this. What is your opinion about curcumin?
डॉक्टर अग्रवाल, मैं एक बात
Yeah.
बात बोलूं। इसी हम लोग
Yes,
तो
sir.
अपनी एलोपैथी से बाहर नहीं जाते हैं, बट इन यूएस वेयर आई एम सिटिंग there is a integrative medicine which is 2-year fellowship, and my daughter and son-in-law has done it. So there they teach you, or they empower you about beyond allopathy in terms of yoga, mindfulness, and herbal drugs. So and that is evidence based. It is not that it is. I have also gone through this one book which is written, and I'm preparing some protocols. So, based on the evidence, they advocate taking these supplements, herbals, which, if you remember, 100 years back in India, Ayurveda was the most important, component. And jokingly, they would make a diagnosis of pregnancy by just checking the pulse. And if you see Hiramendi, the same thing also is shown. So there are ways and means, and curcumin has been found to be highly effective in as an anti-immunity immunomodulator. And so this is basically, I don't know who was there, Saptarishi was there. Autoimmune disorders are as a result of a continuous bombardment of iodine, which we have supplemented in salt. And that, you see, when we were students or residents, autoimmune thyroiditis होता ही नहीं था। और आज के दिन में सबसे कॉमन कॉज ही autoimmune thyroiditis leading to hypothyroidism or pregnancy related. So the one hypothesis is that there is some thing to do with the supplements which we do. So I think excess of everything is bad, but curcumin has been, I agree with you, it has been found. But the evidence may not be that strong, but there is no harm attached to it.
Sir, I'll
Welcome.
just say that I completely agree with the sir's statement that curcumin might not be bad. And there are a lot of evidence that at least in autoimmune diseases, it has definitely shown benefits, sir. But I disagree with sir's statement. I agree with that iodinization of the salt may actually be responsible for the rise of autoimmune thyroiditis that we see. But at the same time, I would like to say that the rise in autoimmune thyroiditis that we see is because of the rampant testing that is done, which was not there 2 decades ago, sir. And that
I
is
agree.
I can show you clear cut data for that. My dad tells me very clearly that itni baar they used to see severe hypothyroidism, and they used to diagnose thyroidism when TSH used to be more than 30-35. उससे पहले तो diagnosis होता भी नहीं था. And अभी तो सर हम हर किसी का rampant testing करा रहे हैं, तो हम pick up कर रहे हैं. Also,
So it is the same with vitamin D deficiency also. 40 साल पहले भी
absolutely,
था,
sir.
पहले भी
होता
था,
ही था
लेकिन
सर, बस वो
आज
अब पिक हो रहा है. एंड मतलब आयोडिनाइजेशन का I do disagree with a lot of aspect of iodinization of salt, but one thing is very clear, sir. One of the reasons that I would say that Dr. Kochipille, who was the founder of the Department of Endocrinology at AIMS, I have to give him due credit that it is considered that he single-handedly improved the economic outcome and productivity of India simply by iodinization of salt. That I have to give him credit.
absolutely.
I think, yeah.
Gone are the days when we used to see, goiters, huge goiters among Muslim population or otherwise also. But
So
now we hardly see any goiters. I think that benefit has accrued because of that.
yes, sir, and that has translated into productivity and lack of cretinism that we see.
तो
So yeah,
मैं तुम्हारा नाम जान सकता सेतु तुम सॉरी मैं तुम्हारी फोटो से पहचान नहीं पाया. मैं तो नरिंदर पाल सिंह हूँ एनपी सिंह.
right, sir.
So
Sir, I'm
Setu is Dr. Rajiv Gupta's son, Setu Gupta, endocrinologist.
ओह अच्छा अच्छा. वेरी गुड बेटा,
Yeah.
वेरी गुड. ग्रेट.
Thank you, Dr. NP, Dr. Setu. I think Dr. Pankaj, please take over.
Yes,
right.
sir. I think I welcome Dr. Professor N.P. Singh, sir, who was joined from US, and last time we had a very wonderful CPC, sir. And from the same beach that you were sitting here, so वहीं से आपने CPC करी थी, sir.
वो सुबह 3 बजे करी थी. अभी तो रात के 11 दिन के 12 बजे हैं पूरे.
It was very well appreciated, sir. Dr. Vijay Roda sir is trying to join because some कुछ technical glitch है उनको. अभी 5 मिनट में join कर रहे हैं, sir. So इससे पहले वो ज्वाइन करते हैं, वी स्टार्ट द फॉर्मल मीटिंग. डॉक्टर एनपी सिंह सर, मैं आपसे कुछ पूछना चाहूंगा आपसे. कुछ
Yeah.
रिसेंट कुछ चेंजेस हुए हैं मतलब गाइडलाइंस में, जैसे इंडियन गाइडलाइंस अभी जो रिलीज हुई है हाइपरटेंशन की, तो कुछ चेंजेस देखते हैं आप सर उसमें कुछ?
So basically, you see, Indian guidelines always follow the Western guidelines in terms of the timing. Now, you see, unfortunately, India does not produce a very strong evidence-based medicine in terms of a very robust clinical trial. So
Yes, sir.
whatever we write, it is the recommendations after the evidence has been accrued by the various trials which we do. So I think the
Yes, sir.
last major trial for high blood pressure was SPRINT trial, which has conclusively
Friends.
shown that blood
Yes.
pressure of 110/70, even in elderly, has been found to be beneficial and prevents the progression. So I think changes नहीं हुई है, except that ABCD formula is still available. But the exciting thing has occurred is because of the availability of this MRA antagonist,
Yes, sir.
Eprinon or Kerendia आ गया है. So that has been found to be a very, very effective tool also in heart failures and preventing the progression chronically. So they have a role in, and spironolactone has re-emerged as one of the very important
Yes, sir.
molecules. Otherwise, मैं तो ये समझाना चाहूंगा कि हमें एक salt sensitivity के बारे में ध्यान रखना है. So whenever
Yes.
given a chance, I would like to talk a bit about what
Yes,
salt
sir.
sensitivity is, how we should address that, and are Indians prone to have salt sensitivity?
राइट सर. दूसरा सवाल ये आता है कि डिस्पाइट ऑफ अवेयरनेस ऑफ हाइपरटेंशन, लॉट ऑफ टूल्स आर देयर नाउ, बीपीएम एंड होम ब्लड प्रेशर मॉनिटरिंग आर देयर. आई थिंक यू हैव टेकन अ गुड लेक्चर ऑफ दिस होम मॉनिटरिंग सिस्टम इन डिफरेंट वेबिनार्स. बट डिस्पाइट ऑफ ऑल दिस, अभी भी जो जो आपका कंट्रोल है वो इट्स नॉट गेटिंग ग्रेट, एंड इट्स अ वर्ल्ड वाइड थिंग, नॉट इन इंडिया. अभी आप देखो, जो अभी जितनी गाइडलाइंस आती हैं वो कहती है कि 20% 22% कंट्रोल है सर, डिस्पाइट टेकिंग मेडिसिन. सो ये कहाँ पे हम लोग लैग कर रहे हैं, कहाँ पे रशिया हम लोग लैग कर
तो
रहे हैं?
आप मेरे हाथ में कोई ग्लास देख रहे हैं? पता नहीं मेरा वीडियो आप दिख
हाँ,
रहा
दिख
है
रहा
नहीं
दिख
दिख.
दिख रहा दिख रहा
So,
ग्लास सर. हाँ.
so I had a walk of almost 10,000 steps and I'm taking Nimbu Pani with shakkar. Now the
सर.
issue is that it is all industry driven. So आप डाइट देखें, आप अभी थोड़ी देर बाद आज तो पता नहीं डिनर है नहीं है, वर्चुअल का ये फायदा है कि डिनर नहीं है. नहीं
जी
तो
सर.
आई वाज जस्ट गोइंग थ्रू वन ऑफ द आर्टिकल्स. पोडोकास्ट, आजकल पोडोकास्ट बहुत अच्छे अच्छे आ गए हैं. तो माय डॉटर एक्चुअली डिड अ पोडोकास्ट ऑन सॉल्ट. So
जी सर.
I think we need to understand that obesity is rampant. Obesity has been found to be associated with so many disorders, including hypertension. And the second thing is regarding the compliance. हम ना नमक कम कर सकते हैं, हम दवाइयाँ रेगुलरली नहीं खा सकते, वेट लॉस कर नहीं सकते, एक्सरसाइज कर नहीं सकते. तो आप मुझे याद है कि जब मैं रेजिडेंट था, व्हेन आई वाज अ स्टूडेंट, द
जी
प्रेवलेंस
सर.
ऑफ डायबिटीज वाज 2% एंड प्रेवलेंस
जी.
ऑफ हाइपरटेंशन वाज 5%. और फिर
जी
अगले
सर.
40 साल में हेल्थ केयर में तो बहुत इंप्रूवमेंट हुई है. बट इंडस्ट्रियलाइजेशन, अर्बनाइजेशन एंड एफ्लुएंस, ये 3 चीजें हुई हैं. इंडिया
राइट
में
सर.
भी हुई है, बाहर में. सो दिस ऑल दी थ्री, industrialization, urbanization, and influence, has resulted in a rampant, and it is the single most cause of the morbidity and mortality all over the world, hypertension. So, but हम
एंड
डेज बनाते हैं, but unfortunately कुछ
And it's
समझाते नहीं
very,
है.
very, sir, irony ke it's the most preventable, cardiovascular risk factor
हाँ.
actually. So, I welcome Dr. Anpane, sir. Dr. Anpane joined as a panelist, and I welcome Dr. Nirupi Agarwal also. She has joined as a panelist. So lot of issues are going on. Dr. Anpane, what is your take on of this rising trend of hypertensive? Are we screening those patients more, or the awareness बढ़ गया, sir? Dr. Pandey, sir. सर अनम्यूट कर लो सर. Dr. Pandey, unmute. हाँ, yes.
Good evening, Dr. Pankaj.
Hello,
Sir,
hello,
good
sir.
evening, Dr. Singh.
गुड इवनिंग डॉक्टर पांडे, हाउ आर यू? बहुत अच्छा लगा देख के, और आपके पीछे की
It's a really
पेंटिंग
pleasure
आपके
to be in the
रिफ्लेक्ट कर रही
platform. Thank you, sir. Dr. Pankaj, सबसे, I mean, first of all, I think it's not only rising trend, it is rising awareness also.
जी सर.
And that is the reason that we are picking up more hypertensions. But I feel, sir, the way we are measuring blood pressure, like if you look at my OPD, I see it's a 20 patient, every patient has the same cough, is rushing from billing to nursing staff. I think doctors have stopped measuring blood pressure even, I'm telling.
जी सर.
So I think we are not serious about this real epidemic. I have not measured blood pressure of any of my patients, I think in max. In my clinic, I'm doing it, but there I think it's total rethought. We have to reload our thought process for managing hypertension. And I think it is not only the rising trend, rising incidence, it is poorly controlled blood pressure. Look at the statistics, not even 20% have controlled blood pressure. So even
Yes,
we
sir.
are diagnosing, but we are doing, I think, not justification, maybe because inertia of prescribing drugs, or maybe not aware about this. We are using very blood pressure monitoring, and I think we have to really upgrade ourselves first to improve the hypertension outcomes.
Right.
And I think education is very important. Early education from, I think, school going kids to different colleges and institutions is very important, because we are getting a lot of young hypertensives.
Yes,
So I think society has to take part and larger interest in preventing hypertension, heart disease, and mortality and morbidity. It's the number one killer, I can say.
So I welcome Dr. Vijay sir. He is the moderator session. There was some issue with his laptop, so I think he can start. Dr. Swati, you can formally welcome our audience.
Good evening,
Good evening.
Pankaj.
Good evening,
Hello,
sir. So good evening, everyone. I'm Dr. Swati. I welcome everybody on the behalf of EDPA on the eve of World Hypertension Day for our panel discussion. I welcome Dr. Vijay Arora to formally start with the panel discussion.
Right. So before starting, Dr. Vijay, take over this thing, I just want to highlight that it is not the way that how we celebrate the things. It is how we get used to aware of this thing. So जो वर्ल्ड हेल्थ ऑर्गेनाइजेशन है वो बोलता है कि भाई आप नंबर पे ध्यान देखो अपना. एंड मुझे लगता नहीं कि मतलब हम लोग एज अ फिजिशियंस वी आर अवेयर ऑफ ब्लड प्रेशर. और पांडे राइटली सेड डेट के हम लोग बीपी नापने ही भूल गए हैं, बिकॉज पेशेंट्स हम देखते हैं और हमारा स्टाफ नापता है कैसे नाप रहा है बीपी, कितना बड़ा कफ साइज है, क्या है उसको. तो वी आर नॉट डूइंग द राइट वे दैट वी यू शुड डू. I also welcome Dr. Nirupi Agrawal, our nephrologist colleague, Dr. Pandey sir, and Dr. NP Singh is joined from US, and definitely will take opinion from him. I hand over to Dr. Vijay Arora for moderation of this, and we'll have some questions with our panelists. Sir. Dr. Vijay, you can share your screen.
So am I allowed to share my screen because it's not visible? Screen share.
Sir, center में है सर share screen. देखिए.
सेंटर में है सर, सबको अलाउ कर रहा है, मेरी भी
सब-
स्क्रीन शेयर, मेरा भी.
सबको अलाउड है सर, मतलब मल्टीपल पीपल कैन अलाउ.
नीचे आप जाएंगे, नीचे कर्सर को करेंगे तभी वो आएगा, नहीं तो छुप जाता है वो. गुड इवनिंग नीरू, कैसे हो?
गुड इवनिंग सर. सर ऑल गुड. आपको देख के एनकरेजिंग लग रहा है.
अरे थैंक यू.
दिस इज द फर्स्ट स्टेप टू कंट्रोल द ब्लड प्रेशर.
That's right, sir. आप लोग हम लोग सब मिलते रहे सर, एक दूसरे से बातचीत करते रहे. आई थिंक दिस इज गुड थिंग. एंड आई थिंक वी आर टेकन दिस इनिशिएटिव दैट हम लोग जो भी डेज होंगे वर्ल्ड हेल्थ ऑर्गेनाइजेशन के, तो विल ट्राई टू ऑब्जर्व और सेलिब्रेट इन दिस वे, सो दैट we get connected and we can abreast our people at what's going on in the world. I think we are quite fortunate that Dr. NP Singh is there in US, and definitely we can have the trend at what's going on. अभी हम लोग कर्कर्मीन की बात कर रहे थे, डॉक्टर गौरव ने बड़ा अच्छा उठाया था कि जो हमारी हब्स हैं मतलब वो कैसे हम यूज कर सकते हैं in practice with evidence based. So Dr. Vijay, can you able to share the screen?
Is it visible now?
नहीं
visible
Yes,
तो नहीं।
नहीं, आप
screen is
सर आप
not.
मुझे शेयर
You
कर
are
दीजिए, मैं
visible.
शेयर कर देती हूँ।
सर जी नीचे जाओगे ना, पार्टिसिपेंट्स के बाद चैट के बाद शेयर स्क्रीन है, थले क्लिक करो, नु कर्सर नु थले तक लेके जाओ।
ये है सर, इसे मोर आ रहा है, शेयर स्क्रीन आ रहा है सर।
हाँ
कर दिया
उसको क्लिक
सर।
करो ना,
जी सर,
उसको क्लिक करो, शेयर स्क्रीन को क्लिक करो।
कर दिया जी, ये भी
तो
हो
फिर
गया।
आपके पास अब अपनी पावर पॉइंट को की उस पे चले जाओ, देयर मल्टीपल स्क्रीन्स आ जाएंगी, तो उसमें से एक आपकी स्लाइड्स होंगी।
सर मैं करता हूँ सर, मैं करता हूँ सर,
आप कर दो सर, आप कर दो प्लीज।
मैं करता हूँ।
Even this can bring up the blood pressure, I believe.
Yes, sir.
Yes, some amount of anxiety, stress, or not being able to.
Sir, what is the situation in United States?
सर सब जगह बुरा हाल है। द हेल्थ केयर, यू नो, they spend close to 22% of their GDP on healthcare, and despite of that, you know, their OECD rank is so low.
सर देखें
तो
ना, स्लाइड देख पा रहे हैं सर?
हाँ हाँ, देख देख वो आपका स्क्रीन दिख, हाँ आ गया।
Yes.
चलो सर, ठीक है सर, राइट सर। सर यू कैन स्टार्ट आउट सर, मैं स्लाइड चेंज कर दूंगा सर आपकी।
So good evening, friends. On World's Hypertension Day, today 17th May 2024, we are having our first meeting of this executive committee, which is online. I welcome our panelists, Vardi Professor N.P. Singh, Dr. Anand Pandey, Dr. Setu Gupta, Dr. Neeru Agarwal, and Dr. Asit Khanna. And with all, Dr. Pankaj Nand Chaudhary, who is the Sarve Sarva of EDPA now, and he will be interrupting in between with the question answer session.
जी सर।
Welcome everybody. We will have small discussion on the basics of hypertension. How should we go? This is just for the awareness of everybody, that how we should present.
जी सर।
I think mute कर दिया
What is
उन्होंने।
hypertension? So there is a continuous relationship between the level of blood pressure and the risk of complications. Hypertension is a major contributor to the cardiovascular morbidity and mortality worldwide and in India also. And starting from 115/75, the CVD risk doubles with each increment of 20 by 10 millimeter of mercury toward the blood pressure range. So if we are maintaining a blood pressure less than 115/75, the cardiovascular risk is reduced or almost negligible. But with every 20 by 10 millimeter increase in the blood pressure, it doubles. So recently, the ACC and AHA guidelines have changed the definition of hypertension to 130/80. However, the European guidelines and many other maintains the early definition of 140/90. The Indian guidelines 4 will continue with the previous definition of 140/90 and also the staging that we followed in IGH3 guidelines. So the hypertension in adults above 18 and older is defined as systolic blood pressure of 140 millimeter of mercury and greater than that, or the diastolic blood pressure above 90 or greater than that, any level of blood pressure in patients taking antihypertensives. So the leading causes in 1990, if you see the leading causes of the death in 1990, they were diarrheal diseases, lower respiratory infections, neonatal pattern, preterm birth, tuberculosis, measles, ischemic heart disease. Ischemic heart disease, the cardiovascular disease, they were at number 6 and number 12. Whereas in 2016, the ischemic heart disease is number 1 in the list of global burden of disease which are studied. And the diarrheal diseases has come down to number 3 level. And if you see the cerebrovascular diseases, they have come up to number 5 from number 12. So there is increased incidence of non-communicable diseases like ischemic heart disease, COPD, cerebrovascular disease, hypertension, diabetes, metabolic syndromes, and PCOS. Next. The increasing trend in death and disability adjusted life, yes, the daily due to high systolic blood pressure in India, the global burden of disease study in 2016. This is the data from 1990 till 2016. And if you see the absolute number, which is almost double from the 1990, and the absolute number in millions daily, it is 20.9, whereas in 2016 it is 39.4. So my request, or the first question, I will request Dr. Professor NP Singh, what is new in Indian guidelines of hypertension number 4? How you see these guidelines help in day-to-day practice of each physicians and cardiologists, nephrologists, and other specialties. My request to Dr. NP Singh, the new Indian guidelines type 4.
Thank you, Vijay, for giving me an opportunity to interact with my former colleagues and friends, and I also feel I'm a part of East Delhi Physician Forum, which is growing leaps and bounds with so many physicians actively. It's a collective effort of East Delhi, unlike other forums where there is a single-handed, driven society. So, having said that, I think India is also now, as we know, will very soon become the third economic force in the world. Now, with that comes the problems associated with healthcare. I think Shashank Joshi, Wander, and Dr. Munjal and others have taken a lead, and Dr. Muruganathan took a lead in starting this guidelines for hypertension. And this is the fourth guideline released around 3 years back, 2019, pre-COVID. Now, unfortunately, as I said in discussion with Dr. Pankaj, is that by and large, except for Rajiv Agarwal from UP, there's hardly any very good epidemiological work, and of course, Dr. Reddy being done in India, and specifically so about the evidence-based medicine in terms of management. So we largely draw our recommendations from the Western evidence-based trials, and as I said, they normally follow around a year or 2 years after the major guidelines which are published by WHO or International Society or European guidelines. So by and large, the fourth guidelines is also in sync with the other guidelines. Of course, unfortunately, if you read the last line, the last paragraph of your presentation, that the health-related toxic effects of mercury are recognized. But still, if you go to any public hospitals or dispensary for that matter, Max is in market minority. Most of the public hospitals are still relying on mercury-based blood pressure measuring instruments, while world over now it has been replaced by, as we were discussing, oscillometry-based methods of blood pressure measurements. So I think that the guidelines have reinforced that we should do away with the mercury-based blood pressure monitoring devices. Then the combination remains the same. The antihypertensive drug, we'll further discuss about that. And by and large, they follow except as you mentioned, they continue to say 140/90 should be sort of labeled as high blood pressure. I maintain that it's a continuum, as has been highlighted in the first slide. See, 110/70 is much better than 120/80, and 125/90 is much harder than 120/80. So try to keep your blood pressure as near normal as possible. For epidemiological purposes, any person, because the lower the blood pressure, if you say that lower the blood pressure defined as hypertension, the higher will be the prevalence. already we have 1/3 of the adult population having a high blood pressure if we measure, if we keep 140 over 90, and if we keep 130 over 85, then the percentage will almost reach 50%. So I think what is important is it should be kept as a continuing. Unfortunately, the first the first approach to a hypertension management are four things: salt restriction, physical activity, weight reduction, and non-smoking, is never implemented. So we go straight to the second arm, that is pharmacological therapy. So one should try our best, as I always advocate, 10,000 steps, more of boiled vegetables, less of, if you see the mushrooming of shops which has occurred in East Delhi or Vaishali or anywhere, you'll find that hospitals cannot cope up with this number of shops which are at night. And as I said, almost to the tune that 10 grams is a normal routine for an Indian. It can be a good thing in summers, but in winters, I think all of us get a 10 millimeter rise in blood pressure because of just vasoconstriction and other factors. So I would say that these guidelines have been in line with the other Western guidelines, and I appreciate the group for releasing it regularly. And this was the fourth guideline released in 2019.
Thank you, sir. Thank you very much. And now, the every time we do some mistake in measuring the blood pressure, if a person is obese and the cuff is small, we are taking the blood pressure which is wrong. And if a person is lean and we are taking using the same blood pressure, may I request Dr. Neeru Agarwal to highlight how should we measure the blood pressure?
Actually, the blood pressure, hello, the blood
Ji, ma'am,
pressure
you are
should
audible.
be actually, yeah, we should not go by the single reading. First thing is the cuff should be appropriate for the size of the patient arm circumference. Second thing, it should not be taken as a first reading. Previously, we used to take 2 readings, but now they say it should be 3 readings taken 2 minutes apart, and it should be average of the 3 readings, which will be ideal blood pressure. But as we sit in the OP days, all of us are in a hurry. We just take 1 reading, but which is not ideal actually.
So, the use of a standard cuff with a bladder size that is 12 centimeter into 35 centimeter. Use a large bladder for a fat arm and a small bladder for the children. The bladder should encircle or cover almost 80% of the upper arm. For measurement, inflate the bladder quickly to a pressure 20 millimeter higher than the point of disappearance of the radial pulse. Deflate the bladder slowly by 2 millimeter mercury every second. The first appearance of the sound is the systolic blood pressure. The disappearance of the sound is the diastolic blood pressure. For children and in those with high output state, muffling of the sound is taken as the diastolic blood pressure. So this is how we check the blood pressure. So what are the precautions, ma'am, and Dr. Neeru Agarwal, we should take in measuring the blood pressure?
The cuff size that you have already told, the
Mm.
readings, the patient should be actually, it should be checked in the left arm. Patient should, the cuff should be at the level of the heart. This is very important because if it is above or low, below, the reading would not be correct.
I think I'll just supplement it with a lot of, I think Dr. Pandey was saying that I have not checked the blood pressure for a long time. So I think it is better if we allow the nurse to check the blood pressure when the patient is sitting quietly, calmly, after having reached the reception 5 minutes earlier. And there are so many variables which can occur. The impact of, the stress, the bladder being full, the smoking having occurred 5 minutes earlier, or rushing, or the blood, taking a huge diet. So a lot of parameters can impact the blood pressure by the tune of 5 to 10 millimeter mercury. So
Yeah.
not only the person should be relaxed, he should not have taken coffee, though coffee is not harmful, but it can cause some mild amount of vasoconstriction. Smoking should not have occurred. And as Dr. Neeru has pointed out, that it is the average of this 2 or 3 readings. Now, most of the good hospitals have automated blood pressure instruments. So all this, rise and other things have been taken care of. But more importantly, the environment should be such that you are measuring the actual amount of blood pressure and not anxiety-driven or stress-driven a slightly higher blood pressure. We'll talk about white coat hypertension as well, but yes, we should try to check our patient's blood pressure at least once in a month if the patient is coming to us regularly, occasionally, just to see that whatever the nurse is checking is correct or not. We can do a
Sir,
random.
From
sir,
this,
it's
we
very,
have,
very important for us to check the blood pressure ourselves. I do
yes,
it many a times because whatever nurse, for her, it is a job to do. But she doesn't understand or realize the value of systolic or diastolic blood pressure or the actual readings. So many times I have found the discrepancies, and as you correctly said, it should be checked by us only, or the nurse should be so well trained that she doesn't take the wrong reading.
we check it most of the time by ourselves, ma'am. And from this questions, we have four different parts. What is, should we allow a office blood pressure measurement? One is home blood pressure measurement. Then is white coat hypertension. Then comes the mask hypertension. May I request Dr. Anand Pandey to enlighten us on these four terms which we are using again and again: the white coat hypertension, the mask hypertension, the office blood pressure measurement, and the home blood pressure measurements.
Good evening, Dr. Arora. I think now we have enough message how to record the best blood pressure. And seeing the OPD rush and number of patients coming to nursing counter and measuring the blood pressure, getting registration. So there are a lot of anxiety and hurry to consult the doctor, and doctor itself is in hurry actually. So I rely so much on home blood pressure recording. And I always say that because that is the place where they can record the blood pressure in very ideal situation. Sitting for 5 minutes, having a ideal right side of bladder, measuring 2 to 3 readings and taking either average of blood pressure or maybe the third one or second reading. So that is the ideal situation which we don't get in our hospitals. I mean, in no hospital, I can say. And there is a lot of data which says that home blood pressure has much more correlation with target organ involvements. Because you are measuring one in 3 months, but the patient is measuring very oftenly at his own environment in a relaxed manner, which is more accountable. So white coat means pressure is high in hospital and normal in home environment. We can guess that which is the ideal suited environment there. And the reverse is the mass hypertension. The blood pressure is normal at office and high at home. I think this is the place where we can use very nicely the ambulatory blood pressure monitoring. ABPM has a lot of role to look at mass hypertension or white coat or dippers or non-dippers, early morning, late evening, consistent. A lot answers can be taken from ABPM. And we are using this in patients where we find that patient PP is very high, recording at home is normal, but hospital recording is high. Our patient says that his pressure is not controlled despite medications. We can, I think, look at the resistant hypertension also. I think so. This is how I practice. I rely more on home BP recording than the hospital recording in the current scenarios.
Dr. Pandey, what was the cause of this mass hypertension? Because the prevalence is 5 to 8%. Actually, it is pretty high actually, and it is correlated to the morbidity and mortality. So, what was the cause of this mass hypertension, sir?
Cause of mass hypertension.
Mass, yeah.
See, it is just reverse of white coat hypertension.
The cause, sir.
There are-
What is the
See, there are a
pathophysiology
lot of
cause? Yeah.
patients. There are a lot of patients. You look at Dr. Pankaj, when you discharge a patient, sometimes the patient is discharged, he's very anxious, pressure is high. The moment they are discharged, they go back home. They find their own environment, they are relaxed and their parameters go normal. So same way, I mean, their pressure is high at home and normal at hospital is basically a mask. I think they should be taken more seriously.
Yeah, yes, sir.
And to look at because the majority of environment which they are living in is their home environment, right? So if we use this good amount of multiple recordings or ambulatory blood pressure recording, I think we can overcome. Majority of times we have to just adjust the doses and timing of antihypertensive or combination pill. I think we can overcome whether it's mask or it's a white coat.
Right, sir.
Sir, this
One of the very important
hypertension. has given so much of insight into the hypertension. This is most of the most neglected part is hypertension. There is so much of noise level for diabetes and its complication, but we forget the hypertension, which is very prevalent. In India, they say that in urban it is 33.8% people have hypertension, and 20 in rural area 27%, and the overall prevalence is 29.8. So every third person is having hypertension, and we are not bothered about checking the blood pressure ourselves, and we rely more of the time on nurses, which is not a very good practice. That is one thing which we should all check the blood pressure ourselves. And if you see the level of control, it is so very poor. Only 20% in the urban area and the 11% in the rural area population, they are having controlled blood pressure. Otherwise, most of the people, they are having uncontrolled blood pressure, and that is the reason for most of the complications. And the large public health measures need to be taken to improve this, sir.
Dr. Vijayawada sir, this is actually a global issue. Dr.
Yes.
Jason can throw a light actually on
This
this.
is Indian scenario. The fourth edition has given this prevalence rate, and which is very high. So after covering this masked hypertension, the white coat hypertension, and the incidence of white coat is 10 to 15%, whereas in the mask it is 5 to 10%. So the masked hypertension was associated with a greater risk of death and than the sustained hypertension.
I think some of the other factors related to mask hypertension are actually there, things like alcohol, smoking, which when they come to hospital, they try to avoid. And OSA is also one of the very important
Right, sir.
parameter in chronic kidney disease. See, non-dippers are the most important people where your blood pressure seems to be okay, but you have a target organ disease. So whenever you have a discrepancy between the blood pressure levels and the target organ, you should always suspect that patient might be having a mask hypertension. So,
Right, sir.
as you have pointed out and others have pointed out that both are equally important. So, there, as Dr. Pandey said, ambulatory blood pressure at least once in the starting, and maybe after every 1 or 2 years, we should resort to this.
Thank
Sir,
you, sir.
can I point out one thing more?
Yes, sir. Yes, sir. Yes, sir.
Dr. Pankaj, there was a very large India heart study, hypertension study,
Yes,
and
sir.
what they found that the average heart rate of Indian hypertensive, especially young, was 10 to 13 beats more than the Western counterpart. A lot of anxiety has played a role in young hypertensive, which we have seen in our counterpart. So that is why there is a little role of beta blockers in this subset of patients, which I think no guidelines supports us. If you look at any guidelines, beta blockers are coming third and fourth. But there is good subset of patients, so young patients where heart rate is very high. You can see the resting tachycardia is there. I think they are the patients who need a lot of reassurance and then a good role of beta blockers in
Right.
these patients.
Right. So what we call a sympathy overdrive. I think this is
Yeah,
very true.
this is very
that you're coming to. Yeah.
one third of young hypertensives in India have a very high sympathetic drive actually.
Right, sir.
Thank you, sir. So, what are the special features in the hypertension in Indian scenario? I'll request Dr. Setu to take over this question. Dr. Setu, please.
All right, sir. So, like the slide says that in India, the special features are that there is an early onset that we see. Young hypertension is quite significant in India. There is a rural-urban divide in prevalence. We assume that the urbans are much more. The prevalence is high, but we can see from the ICMR India B data that the rurals are also catching up. So this divide is not really that prevalent now with the latest data, but yes, nonetheless, the urbans are overshadowing the rural when it comes to that. And then again, we have a clustering of multiple cardiovascular risk factors. We have diabetes, we have obesity, we have dyslipidemia, which we are very prone to. So multiple cardiovascular risk factors, they coalesce, and that provides a steady ground for cardiovascular events to occur. There is significant seasonal variation of blood pressure. And then there is overall the average blood pressure is rising in the general population. So it's a paradigm that has been seen in US. There is the obesity, the BMI, overall BMI is averaging out to be higher. The same as what is happening in urban population. The same as what is happening with hypertension. The same as what is happening with LDL cholesterol. The average LDL cholesterol, the average systolic blood pressure it's all rising as the prevalence of hypertension per se is rising. That's why the definitions of hypertension is not based on what is the median in the population, but rather at what blood pressure and organ damages occur. Again, there is low awareness, treatment and control rates, probably because of the therapeutic inertia that somebody talked about is there in the minds of the physicians, that we tend to be slow in escalating our antihypertensive dose, and then we have HMOD. I'm not sure. Can somebody help me what this would be?
This is hypertensive-mediated organ damage.
Okay, so end organ damages, yeah,
Yeah,
possibly
yeah.
due to poor control.
Yes,
Yeah.
sir. So, if further adding, there are three classifications, and as per our fourth guidelines of API, RSDI, and there are three stages in the hypertension. Stage 1 is 140 to 159 systolic and 90 to 99 diastolic. Stage 2 is 160 to 179 and 109. And stage 3 is more than 180 and more than 110 is the stage 3. So, what is isolated systolic hypertension? And when the grade 1 is between 140 to 160 and diastolic less than 90, and grade 2 is more than 160 and less than 90. So, what exactly is the isolated systolic hypertension? May I request Dr. Asit Khanna to kindly enlighten us?
Asit is there?
Sir, I think Dr. Asit didn't join. He could not join.
Okay, Dr. Pankaj Anand, please enlighten us.
Right, sir. So as you rightly said that no, isolated systolic hypertension, and normally we see this systolic hypertension in elderly, where the compliance is getting deranged in elderly patients, and this isolated systolic hypertension actually is correlated to the higher mortality in particular age group, like more than 60, 65, 70 years. So actually we missed this specific thing. ISH is isolated systolic hypertension, but diastolic blood pressure normal, and this is because of in elderly the tone is decreased, so that the systolic the difference of the pulse pressure is low. And we are also cautious about these patients that postural hypertension is very common. Sometimes you check the blood pressure when the patient is supine, blood pressure is say 160 and 80. And when you ask the patient to stand, and blood pressure fell dramatically. And in the one of the conference that attended API, the posterior hypertension is a very important issue of the increase in mortality in this particular thing. I think Dr. NP sir can throw the light on that.
So I think very rightly put, with the age, as we age old, we become stiffer. Our vessels also become stiffer.
Yes, sir.
So there are two important things which we need to consider. One is the pseudo hypertension and one is the real systolic hypertension. Unfortunately, we do not measure the intra-arterial blood pressure. So we rely on indirect method. And when we try and measure the blood pressure in an elderly individual, one should always try to at least once do what is known as oscillus phenomenon. I think someone can mute.
Shambhu can
What
mute
is
because
Satish hai? So what is oscillus phenomena is what is known as pseudo hypertension. When it is actually caused by the calcification of blood vessels, they don't get compressed. Remember, it is an indirect method. We are trying to compress the vessels and see the blood pressure readings. So when we have a calcific vessels, they don't get compressed, and then it will require more effort for us to compress those vessels, resulting in what is known as falsely higher blood pressure. These are the patients, when you start antihypertensive, they tend to come to us with symptoms of postural hypertension because their intra-arterial blood pressure is not very high. So I think what is important is, on one hand, look for this pseudo hypertension, but on the other hand, you must address the role of systolic hypertension. Now, again, some of the drugs like calcium channel blockers and diuretics, it is normally said that these systolic hypertension is more of a salt-sensitive hypertension. And what do you mean? What do I mean by the term salt-sensitive is when we eat, let's say, 10 grams of salt, very promptly, most of us will excrete that salt in the urine in next 4 to 6 hours or 12 hours. But there are certain individuals, especially those who have avid salt and water retention, they do not excrete the salt load. And that is why they have what is known as salt sensitive hypertension, and this has been very shown very elegantly in experimental studies. They tend to respond very well to calcium channel blockers and diuretics, and they are the ones who who
Shambhu,
present over.
kindly mute the audience, please. Shambhu?
I think Dr.
Achi.
Sarojwari and Rajiv and Vijay Arora is. It is important for us to understand that systolic hypertension is more commonly, of course, unless there is a secondary cause like thyrotoxicosis, anemia, and aortic regurgitation, they are very rare causes. But by and large, systolic hypertension is occurs more common in elderly, responds better to diuretics and calcium channel blockers. But before we label the patient as having systolic hypertension, we must rule out pseudohypertension through the Osler's maneuver.
Thank you, sir. So another way of classifying hypertension is primary or essential hypertension and secondary hypertension. 80 to 95% of the people of hypertension, they are having primary hypertension or essential hypertension. They are when there is no identifiable cause, but they are having strong family history. And 5 to 20% people have hypertension, which is secondary hypertension. There is one or other identifiable cause is there, which we can identify. So there are certain predisposing factors for the primary hypertension, including hereditary predisposition, age, gender, ethnicity, socioeconomic status, salt intake, as rightly pointed out by Professor N. P. Singh, sedentary lifestyle like us, obesity like me, smoking, insulin resistance, diabetes, dyslipidemia, metabolic syndrome, and stress. So all the factors I have, and must be having primary hypertension. So these are the predisposing factors we should all be careful of. So
sir, you're talking, sir, Dr. Anpising sir is actually talking about the salt. So, sir, according to you, what would be the ideal, salt intake in a normotensive people versus, hypertensive patient? Because there's a lot of contention in that, in different guidelines.
So, unfortunately, I would suggest that normal salt intake, in a normal
Yes, sir.
adult, like
Yes, sir.
let's say, I don't know about Vijay, but my blood pressure is 110/70. So normal salt
I also
intake.
have the same, sir.
Very good, Vijay. So I know that you do a lot of other things which will help prevent. So I think it should be 50% is a natural salt which we eat. हम खाना खाते हैं, सब्जी में होता है, बाकियों में होता है, and 50% is the add-on salt, पकौड़ों में या अचार में या पापड़ में. So I think it should be definitely less than 10 grams. But again, I think once at least, though it is more experimental, लेकिन कभी भी मरीज अगर हमारे पास आता है तो हम उसका एक बार ही उसको एक ब्रेड पकौड़ा खिला के या एक्स्ट्रा सॉल्ट खिला के एक यूनरी सोडियम करके देख सकते हैं. So if he is able to excrete his salt,
Sir, ideally normal salt intake should be 5 grams per day.
Yeah, so I'm coming to that. So ideally it should, लेकिन होता नहीं है नीरू, exactly I'm saying, but definitely in patients who are hypertensive or who have less than 5 grams is what is educated, and chronic kidney disease में 3 ग्राम भी होता है. But
3 grams
कोशिश यही करनी चाहिए कि एक्स्ट्रा सॉल्ट ना खाया जाए, बट होता नहीं है.
चटनी पापड़ अच्छा.
After describing the predisposing factor of primary hypertension, may I request Dr. Neero Agarwal to tell us how to find a secondary hypertension patient. What are the clues to secondary hypertension patient?
So, any patient who is young and comes to you with hypertension should always be evaluated for secondary hypertension. And if patient is edematous, patient is having high BP, Cushingoid faces, very lean and thin and very high blood pressure. So all these are the situation, and plus our renal cases like acute glomerulonephritis, they would have proteinuria, hematuria, cast in the urine. So all these patients should be actually evaluated for secondary cause of hypertension.
Setu, in your practice, how many cases you see of secondary hypertension? Because you must be encountering those patients. Dr. Setu.
So for me, I just want to say that we are missing out on a lot of primary aldosteronism. So it's not necessary that young patients or patients who are more than 3 antihypertensive, yes, definitely we need to screen them. But I have screened because as per the newer guidelines from the European societies or from the endocrine societies for that matter, they say that the prevalence of hypertension So the prevalence of primary aldosteronism in hypertension, in all hypertension, is 10%.
It's
And
quite high.
so it's quite high, sir. It's just that we are not screening it. And even the data that we had from AIMS, we found that even when we started screening all hypertensive patients, the prevalence was around 12%. This was published 2 years ago. So
Right.
we have a lot of, and so particularly because I am biased, because I have an area of interest in endocrine hypertension, so I tend to screen and I tend to pick up a lot of patients. Over the past 1 year of my practice, I have now 32 patients of primary aldosteronism.
So what is your message to the physicians, like we are treating hypertension? So when you suspect that the patient is having primary
Sir,
aldosteronism?
Sir, I would say do not look at potassium, sir. Low potassium is only in 20% of cases of primary aldosteronism. It should not be the one that triggers ki we need to screen. Any patient who is young, less than 40 years, and is on more than 2 antihypertensives and still the systolic and diastolics are not controlled, think about PA. It's gonna be
Right.
there, sir. Matlab 50% of the time you'll find PA, sir.
So what are the basic tests you would order this to talk to this patient?
So the problem with PA is that you cannot run the test on ACE inhibitors and ARBs. I mean, there are a lot of antihypertensive that you need to play around, but the major confounding antihypertensive is your ACE and ARBs. And unfortunately, we all tend to love using ACE and
Yes,
ARBs.
yes.
So what?
Yes. Most of the patients, yeah.
Most of our patients. So I would say that just switch from ACE ARBs to alpha blockers or CCBs, and just do after 4 weeks of washout, just do a plasma aldosterone concentration and direct renin concentration. And here I'm saying direct renin instead of plasma renin activity, because plasma renin activity is a very laborious lab intensive test. So there tends to be a lot of ifs and buts when it comes to analyzing that result. So plasma aldo and direct renin. If your direct renin concentration is less than 10 micro international unit per ml, and your plasma aldosterone concentration is more than 20, you have practically screened the patient for PA and the patient is screening positive, and then we can go for confirmatory tests.
Right.
Dr. Pankaj, here I want to say, normally
Yeah.
the tendency for physicians is that whenever they see a patient of blood pressure, howsoever the age is, they just start the antihypertensive and no further evaluation is done. But it's very important for the young patient, even for the elderly, because young patients would be having renovascular hypertension and endocrine related hypertension. This is one part. Plus, underlying renal disease can also be there. Similarly, in the elderly population, we simply add the antihypertensive, but that could be related to atherosclerotic renovascular disease, where renal artery stenosis, which could be correctable factor, is being missed. So evaluation should always be done. Just don't manage the patient with antihypertensives, because when we see many patients with CRF, we feel that at the earliest point of time when their hypertension was diagnosed, it could have been corrected.
Absolutely,
Yeah, right.
ma'am. One more thing I'll just add here, ma'am. So that is why I love screening everybody with renin and aldosterone, because if renin comes more than 100, then I know that this is renovascular. So instead of getting all the Dopplers and the CT angios as a screening test, renin very categorically has shown, and I have picked so many renovascular just by a high renin in that scenario.
So I'll give you an example. I saw a patient. He was around in his 40s. He said his BP is being controlled, but he continued to have high blood pressure and some pain in abdomen. I thought it could be renal vascular hypertension. I got an MR angio done, and this patient had coarctation of aorta. So evaluation helps. Screening helps.
So, ma'am, screening, as Dr. Setu has said, that he will prefer to go for renin level or aldosterone renin ratio.
So, but at least, sir, prelims should be done.
So
yes,
I think
but it is very difficult to ask the patient, because the ARR is costing around 7,600 rupees for any patient where we are suspecting this. And if you go for a simpler Doppler test and ask for microalbumin or simple renal resistive index, how safe it is to go by renal resistive index than by going for ARR in every patient of who is suspecting secondary hypertension?
So prelims should be done, but if there is slightest of suspicion that even if these tests are normal and still patient, you still feel, then go for all these blood tests, which are costly. But yes, if they can help to make the diagnosis, but not in all the patients from the beginning.
ठीक है मैम, थैंक यू।
This I would disagree with ma'am. Ma'am, I would think that a 7600 test gives a lot of benefit to the patients in the long term. If you look at the economic burden of the complications of hypertension, 7600 at a screening is not a big thing, ma'am.
So I'll just
So this is
come
one
in
test.
between.
And ambition sympathizer, sir, please.
So
Dr. Vijay, one
there are
thing, I mean, very important clinical clues which are there for secondary hypertension.
Yeah.
Because we are seeing
Yeah.
every patient hypertensive.
Yes, sir.
Yes.
Unprovoked hypokalemia, that is one. Potassium is 2.4, 2.5. Though may be uncommon, but it's very common to think for secondary hypertension. Second, disparity in kidney. Say, ultrasound is very simple. You can get ultrasound. I get every hypertensive patient my ultrasound. If the kidney size, there is a disparity in kidney size, I think that is secondary cause. Unexplained and disproportionate rise in KFT, derangement of KFT by ACE inhibitors. It's very good clinical. They are very good
Yes, sir.
clinical
Yes.
clues for
Yes, provocative
diagnosing
test.
hypertension. I
Yes,
think
agree.
just measure all the four pulses and four limbs. You can find coarctation of aorta. Aortoarthritis. I remember there was an intern in emergency. He said patient is in shock. When I looked at patient was so comfortable. I said it is aortoarthritis. You look at the pulses. You will not find there any pulses. You measure their blood pressure wherever you can, whether it's a limb, lower limb, or thigh. So a lot of clinical clues are always there to pick up secondary hypertension. I think because of hurry and loaded with the patients, we may miss. But if you really put your clinical sense, 90% time by clinical clues you can pick up secondary hypertension.
Roto has highlighted the clues actually. So this is a very interesting slide. So you can look into it, and we can go after you have got a clinical clues. You can make a proper diagnosis by specific testing after that, right? And I think this would be the approach to this patient, sir.
I think
Thank you.
as he was saying, Setu was saying, any young patient or any patient requiring more than 2 or 3 antihypertensive, or any patient with a disproportionate cardiovascular target organ or atrial fibrillation, one should always investigate for with the aldosterone renin aldosterone ratio, and rule out the secondary, rule out primary hyperaldosteronism.
Right, sir.
Thank you, sir. So, if you see the hypertension, what exactly is the mechanism of hypertension? And Dr. Setu, can you explain a little detail about this so that we can plan our treatment according to that, according to the pathophysiology of this hypertension?
Right, sir. So, as we can see, basically, there's going to be 2 or 3 major components that are going to play together and that are going to have they create a vicious cycle, because of which things go on into an overdrive. So, as has already been trained, there is a sympathetic overdrive, which is a part and parcel of your CNS factors, where a lot of stress plays a role. The CNS goes into a sympathetic overdrive. There is an adrenergic drive. The your alpha and the beta receptors, your beta receptors at the heart, they go into tachycardia. Your alpha receptors at the level of blood vessels, they cause vasoconstriction, which leads to increase at the end of the day, increase in cardiac output and increase in vascular resistance, which manifests as hypertension. So that is one mechanism. The second mechanism is that the central drive also end up increasing the renin levels, which is doubtful, but yeah, it is assumed that the primary event is increase in sympathetic overdrive, which also act by increasing renin, which then act at the level of adrenal glands, release aldosterone. This aldosterone ends up causing water and salt retention, which ultimately increases the vascular resistance and leads to hypertension. And this would be the basic bow. But there is no hypernatremia because there is sodium escape. And in case there is a vascular component, in case there is a renal vascular component, then the juxtaglomerular cells at the level of the kidney, they sense that the afferent arterioles are not getting enough preload, so they end up releasing renin, which ultimately acts at the level of the adrenal gland, and then this is aldosterone secretion, and then we again go for sodium hyperdrive and vascular remodeling. And the third would be the adrenal gland secreting aldosterone independently. So basically, we can divide it at the level of high renin, normal renin, and low renin hypertensions. That is how, as an endocrinology, I approach hypertension. And then we have the complications of hypertension. So basically, they occur at the level of cardiovascular, which can be cardiac, which can be vascular in the form of stroke, and then they can be renal, which manifests as microalbuminuria, CRF, and then all of them combined together act upon each other. The low cardiac output or a low cardiac output will ultimately lead to CKD, and vice versa. The high incidence of CKD also leads to high cardiovascular events.
Pankaj, if you can request Dr. Saroj Kumari Prakash to mute herself.
Right. Actually, I'm sharing the screen. I cannot. Shambhu is actually host now, so I'm just calling him. Okay? Right.
So,
right. Okay.
Pankaj, so that would be from my side.
Yeah, it's okay. Yeah, it's fine.
I think we can skip this normal physiology.
Yeah.
Time come or
right.
management.
So, right. So we can go up to right. We have already the physiology on it. Now evaluation, I think, is more important.
Evaluation. How to evaluate any patient with hypertension? Dr. Pankaj, you please tell us about this.
Right. Okay, so it's very important that now you have diagnosed the hypertension with the methods that already been alluded by our speakers, right? So you have to document hypertension, three objectives, right? To identify known causes of high blood pressure, number one. Second, to assess the presence or absence of HMOD. This HMOD is basically end organ damage or hypertension-mediated organ damage. Now this terminology has been changed now. And to identify the other cardiovascular risk factors or concomitant disorders that may define prognosis and guide treatment. So you have to look for the medical history, for example, duration, symptoms, personal history, family history, personal habits, socioeconomic status. As we already said that there is some disparity between rural and urban, and definitely education status. So you have to identify the relevant history and physical examination. For example, the duration, the previous therapies, family history is very important. Dietary and psychosocial history. Dr. NBC sir is actually giving emphasis on the salt intake. Alcohol consumption is very important. And I think it's very true that patients, when come to the hospital, they have a normal blood pressure and go home, right? They have the high mass hypertension probably because of smoking and alcohol, and OS is one of the risk factors, right? Other risk factors like weight changes, dyslipidemia, smoking, diabetes, physical inactivities. Evidence of secondary hypertension we already discussed. Then evidence of target organ damage, like for example, the history of TIA, stroke, transient blindness, angina, myocardial infarction, congestive heart failure, sexual dysfunction. Sexual dysfunction is very important, as we all know that patient having diabetes and having that erectile dysfunction, it is a harbinger of the cardiovascular disease. So it has to be asked specifically. Physical examination, you have to look for the body habitus. You have to check the blood pressure in both arms, supine and standing blood pressure to rule out this postural hypertension. Fundus is very important, right? Because we actually tend to forget that fundus examination, and sometimes when you do the fundus, you can see the early changes of retinopathy, and it's very important. So every patient, I think 6 months or a year, a patient hypertensive, you should order a fundus examination to each and every patient with hypertension. Then quality of femoral pedal pulses, vascular abdominal bruise, cardiac rate rhythm, signs of congestive heart failure, and characteristics of secondary hypertension, as already discussed. So this is all that we have already said, that record 3 blood pressure readings separate by 2 minutes, record height, weight, and body mass index, examine the pulses, look for the arcus finalis, acanthus nigricans, xanthelasma, xanthoma. They are the indirect markers for metabolic syndrome or insulin resistance. Examine the neck for carotid bruise, JVP, enlarged thyroid gland. Sometimes we are discussing the thyroiditis in previous, when we started. Examine the heart for abnormalities in rate rhythm, apex speed, fourth heart sound and murmurs. Examine the lungs, examine the abdomen for bruise, examine the optic fundus, and definitely you have to thoroughly examine the patients. Then there are a lot of factors which influence responsivity. I asked Dr. Anand Pandit that how he actually go for the screening of cardiovascular disease. Dr. Anand Pandit, sir. Dr. Anand Pandey?
Dr. Anand Pandey, please.
Right, I think it's probably on mute. So these are risk factors for coronary artery disease, like and on the left side, age, male sex, postmenopausal women, diabetes. family history of premature coronary artery disease. OSA is very important, as we have already discussed. High LDL and total cholesterol, low HDL cholesterol and high triglycerides, HSCRP and estimated GFR. Then there is hypertension-mediated organ damage like LVH, microalbuminuria, urinary ACR, ultrasound radiological evidence of atherosclerotic plaques in the carotids, hypertensive retinopathy, and ABI less than 0.9. And the other associated clinical conditions, that is ACC, that is cerebral vascular disease, heart disease, renal disease, vascular disease, and advanced hypertensive retinopathy. Now, I want to ask Dr. NPC sir that a lot of patients are coming with the HSCRP, and they say that okay, this is the risk factor for development of coronary disease. So, how you find this HSCRP, the
So,
logic of HSCRP?
Pankaj, this is our next question. The lab investigation of hypertension. I'll
Yes,
request
sir.
Dr.
So I'll just
Professor
club the
Andrew.
two. I think what is important is there are certain basic investigations which should be done in almost all patients who come to with high blood pressure. A simple urine examination, a hemoglobin estimation, whether he has polycythemia or anemia or not, a serum creatinine examination, a lipid. You don't need to go into an extensive lipid this thing, but basic triglyceride and cholesterol. Then doing an ECG and echocardiogram and possibly an echocardiogram is all that would try to pinpoint whether the patient has a target organ involvement and additional cardiovascular risk factors. And if you have a high index of suspicion, HSCRP is more harped than unfortunately Indian patients, many of them actually
Yeah.
have some form of a mild chronic inflammation, so their CRP levels may be high. But yes, HSCRP is being found to be one of a good single risk factor for CAD. But I would not go only by a single HSCRP report. I will also try to look at now, more importantly, as Sujit mentioned, that if you have some suspicion of a secondary hypertension, then do the second set of investigations. Do a urinary protein to creatinine ratio, look at the other endocrine, test, and do a color Doppler and certain test. Do a renin-angiotensin levels in a specific situation. You can't order these investigations in all the patients, but all patients should have a hemoglobin, a blood glucose, a serum creatinine, potassium. Again, though it is, he has mentioned that potassium, don't go by potassium, but there are young hypertensives, a lot of other genetic conditions with monogenic hypertension who may present with hypertension and hypokalemia. Then, obesity related illnesses are again a very, very important thing. So these are certain which you have highlighted. HSCRP and microalbumin in special circumstances when that can categorize the patient into a high risk cardiovascular disease. So, but many a times we advise certain investigations, we don't interpret it. Creatinine of 1.2 is ignored. A presence of 1 plus proteinuria is ignored. Ultrasound showing a cyst is advised but is ignored. So all these are very, very important investigations which not only should be advised but also should be seen and acted upon.
Right. So I think the sleep study is also taken a good, because
Yes,
patient
yes,
had the
I
daytime
agree.
drowsiness and, patients coming with hypertension, not controlled, but two
So
or three
you just
antihypertensives.
just perform
Yeah.
an
Yeah.
effort screening test, effort scale screening test, and if the patient has positive, history of daytime sleepiness,
This is
watching TV and just sleeping off, or while driving, and then we should resort to, at least a
policy.
screening test for polycystic. So, and in VAX, we remember many have diagnosed
Yes,
many
sir.
cases which were reversible causes of hypertension.
Yes, sir.
And
So I think we
Right.
have 10,
Sir,
10,
I
10,
just
10,
want
15
to
minutes.
just Hi, sir. Pankaj, sir,
Yeah.
just a very, very short addendum.
Yeah.
When I said do not look at potassium, I meant to only diagnose primary aldo. That is all I meant. If there is a young hypertension with hypokalemia, 95% times it's going to be an endocrine or a tubulopathy. And it's going to be, a monogenic cause of hypertension. That's 100% there, sir. Hypokalemia
right,
and a young
yeah, yeah.
hypertension means that this is an endocrine disorder. You may include, Barter's as a part and parcel of it or not. That is debatable. What I meant to say was that
Yeah,
normokalemia
we
with
understand, brother.
hypertension. Yeah, sir.
Yes, sir.
Bas.
Yes. Right, Dr. Suki.
Thank you.
And over to Dr. Sir.
डॉक्टर अरोड़ा जी भी तो सोते नहीं
Sir,
है
namaskar, sir. Hello. I was
Yes,
just
sir.
waiting for Siddharth Setu to complete the sentence.
Yes,
So
sir.
now our next step is how to control, or what are the lifestyle changes we should be adopt in controlling this blood pressure, sir? The non-therapeutic measures which we can take care of hypertension, sir.
And
So I
patients
think the
can, do, yeah.
four important pillars of non-pharmacological measures are weight reduction. I think they all intertwined. Weight reduction, a diet which is dash eating diet, a sodium restriction, and physical activity. And of course, I would propagate more virtual meetings because alcohol can be avoided that way. घर पे बैठ के लोग कम पीते हैं, but after the meetings ज़्यादा पीते हैं. So I think very, very pertinent. I had a very senior, IS officer who convinced me that he will stop taking his calcium channel blockers and beta blockers, and he could do that with the physical activity. Activity can be of all the three types. I think yogic exercises along with isotonic exercises can help you a lot. The same will help you in weight reduction, but your diet then plays a very important role. I think DASH diet तो नहीं, मतलब जो भी हो, मेडिटेरियन डाइट हो, डैश डाइट हो, सब्जी उबाल के कोशिश करो, सब्जी उबाल के खाओ, कोशिश करो कटोरी छोटी रखो, एंड fruits and vegetables. I think we in US here, they always eat 4 5 types of different types of fruits and vegetables, and less saturated total fat. So total quantum of calories should be reduced, and as been highlighted, the less the better as far as salt is concerned. And a good physical swimming is such a beautiful exercise. Unfortunately, we are not used to that, but here in US, almost everybody goes for jogging, swimming, and yes, of course, ये सारी चीजें तो कोला और ये का कल्चर जो है, I think cold drink is one of the, if you check the pH of a cold drink, it turns out to be 3 or 4, so acidic. So we should avoid these Ajinomotos, baking powders. I think this is a slide from Indian guidelines. तो एक तरफ से हम नमक खाने में तो नहीं डालते, बट अचार और पापड़ साथ में ले रहे हैं. So all these are very high ones, and of course this is now he's gone to physical pharmacological management. So please ensure that we change our habit of eating a Mediterranean type of diet, doing some physical activity, and avoiding smoking and alcohol.
Thank you, sir. Thank you very much. And may I request Dr. Anand Pandey to highlight about the pharmacological part of hypertension, what drugs we should choose, and how we should choose according to the patients. Dr. Anand Pandey, please.
Is he there or is he left, sir?
I think he must. Dr. Neero Agrawal, please help us.
वो ऑनलाइन तो जुड़े हुए हैं, लेकिन साथ में एंजियोप्लास्टी भी कर रहे हैं लगता है.
जी सर, हो सकता है.
Dr. Neero Agrawal.
So I think we have 4 5 classes of drugs. We all know very well.
Yes, sir.
ACE inhibitor, ARBs have now emerged as one of the key medication pharmacological treatment of hypertension. On other hand, we have calcium channel blockers, we have diuretics, we have beta blockers, we have certain central sympatholytic agents, and alpha adrenergic antagonists. I think the 4 important drugs which we use it in 95% of the cases are ACE inhibitors, ARBs, calcium channel blockers, diuretics, and beta blockers. Now, there have been clear-cut guidelines on how to use one drug over a combination drug, when to use ACE inhibitors. I think all over the world now, ACE inhibitors and ARBs are the treatment of choice unless there are compelling indications. So Dr. Pandey talked about that young hypertensive who had anxiety. I would rather start him on beta blocker and then add ACE inhibitors. And as I talked about salt-sensitive hypertension, especially in elderly, diuretics and calcium channel blockers may hold an edge over other drugs, but by and large, all patients less than 60 ACE inhibitors, ARBs, and more than 60 calcium channels and diuretics always give a combination. The combination can be in a single pill, and it can be a good combination. Good combination is ACE inhibitors, ARBs plus a calcium channel blocker or a diuretic, and ACE inhibitors, ARBs, and if the patient has a sympathetic overactivity, a beta blockers. A calcium channel blockers and diuretic combination may not be very effective because both are natriuretic. So one has to go and that, and always look at the underlying comorbidities and the target organ disease. The patient has CAD and heart failure, then beta blockers would actually be a good drug. Keep your blood pressure 130 over 80. In elderly, the target can be slightly flexible, but now sprint trial has shown that the lesser the better. And OSA, I think one important thing is that I have known at least 5, 6 senior doctors who were taking 2 antihypertensive drugs, but when they started taking CPAP at night because of OSA, the antihypertensive requirement came down significantly. Similarly, alcohol. I can give you a classical example of a bartender who required 4 antihypertensive drugs. I was able to convince him somehow or other to stop taking a huge amount of alcohol, and his blood pressure dropped to 90/60 after he quit alcohol. So there are certain individuals who have alcohol-mediated hypertension, obesity, and OSA. So we have to look at that. I think I'll stop at that and then let
Right.
others also
Thank you,
speak.
sir. Thank you, sir. The next slide will show the mechanism of action of these drugs. We are omitting this, but it's a very good slide. Our PG must go through this slide.
This is for postgraduates to remember, actually.
Pardon?
There's a slide for the postgraduate to remember mnemonics.
Yes, we have made according to that only. So most of these things has been covered by Professor N.P. Singh in this slide. Especially in patients with coronary artery disease and other patients who are elderly, as rightly said by Professor N.P. Singh, we should choose the drugs which suits our mechanism of action of this disease, and especially in patients with HEPREF and in patients who are having HEPF. So the aim is to maintain the blood pressure, and likely in patients with OSA, we can reduce the dose of antihypertensive by rightly applying the auto CPAP or the BiPAP according to the needs, sir. Thank you very much, sir. What are the general guidelines for selecting the drug treatment for hypertension? Dr. Pankajan Chaudhary.
Yes, sir. So, sir, we'll just go through because the time is actually almost 10 to 11. So, there are specific reasons like patient with hypertension with diabetes, definitely the first option.
So, are all ACE inhibitors alike? Dr. Pankaj?
I think he was also
Sir,
probably
you're
got
not audible, sir. Pankaj, sir.
Yeah, Pankaj is not speaking, so he has to be speaking to be audible.
No, he's not sleeping, sir.
I think almost all the ACE inhibitors have similar efficacy. The potency may vary. Some may be requiring a 10 to 10 milligram. Others may be requiring 20 milligram. Some drugs need to be given once a day. Others need to be in twice a day. Ravinder Makkar has asked a very good question. Beta blockers should be many young male anxious hypertensive can cause loss of libido. Any comments? Uh, yes, that loss of libido may be much more due to anxiety and hypertension than beta blockers, but definitely that is an issue. If there is a specific cause and effect relationship between beta blockers and libido, which I think is more hyped than actually it is there, then we can change over to other drugs. ACE inhibitors, ARBs are also effective in this situation. But those who are anxious are more likely to have concerned about loss of libido. That is what this thing is. So all ACE inhibitors are equal, I think, in terms of their efficacy. But there is a entity which you should always remember. ACE inhibitors can cause cough, which can sometimes be very troubling. And we've done a thesis on that, and we found out that just an iron supplementation or change to ARBs may help. Rarely, ARBs can also be associated with cough. Now, I think efficacy-wise, by and large, all of them are efficacious. I won't call one over others. There are some other additional advantages of people causing decrease in the uric acid level, etc. But by and large, these are. I think what is exciting about management of hypertension, diabetes is these SGLT2 inhibitors and mineralocorticoid receptor blockers. So now, invariably, SGLT2 inhibitors have emerged as one of the very, very key. Like we used to have steroids, beta blockers, and now they have emerged as drugs with multiple actions, including treatment of hypomagnesemia. So I think these drugs should be given in whenever we get a chance, especially in patients with diabetes. And again, I would call back other speakers to say something.
Dr. Neeru Agarwal, please help us in telling in the management of hypertensive emergencies. Dr. Neeru Agarwal.
Ravinder, exercise does increases the blood pressure, but it is only a short-term gain. You know, there is a tachycardia, and if you look at the athletes, their heart rate is 60, 40, 30, I also seen. So, exercise is never a risk factor for hypertension. It may increase the blood pressure transiently, but overall, it is highly beneficial. It will modify, it will give you a chance to reduce the heart rate to improve your cardiac output.
Dr. Setu,
Pankaj has come back again. Pankaj आ गया, डिनर कर लिया पंकज ने.
जी सर. Dr. Setu.
Yes, sir.
Can you enlighten us regarding the hypertensive emergency drug uses?
Hypertensive emergency drug uses, sir. I would say that anything. Well, I would prefer using CCBs, short-acting CCBs, and alpha blockers. That would be my preferred agent to begin with, just in hypertensive emergencies. I've seen so many times people tend to use beta blockers in the first go, and then the patients have turned out to be pheochromocytomas on further evaluations, especially the naive patients who present for the first time. So I've become very wary of using beta blockers in the first go, sir.
But nowadays, enalapril, hydralazine, labetalol are also available as antihypertensives.
Ma'am, in the emergency, I absolutely agree, ma'am. But labetalol we use very commonly, but ma'am, like I've said, young hypertensives, I've seen so many pheochromocytomas worsening because of that. That's all just I wanted to say.
Dr. Setu, how many patients do you see in PHOs in your practice?
So I would say not as much as I see primary aldos, but so because I am practicing in a referral center, मतलब गंगाराम में तो बहुत सारे referred patients आ ही जाते हैं, ऐसा urologist भेज देते हैं, cardiologist भेज देते हैं. So मेरा थोड़ा biased है, but if you ask me in my own, dedicated clinic practice where it's not referred, then obviously sir इतना ज़्यादा तो नहीं है. It'll be I would say once in 2-3 months, but because of referrals, I do tend to see 1 in 2 weeks also, sir.
Then Setu, Dr. Setu, how you treat hypertension with diabetes?
So hypertension with diabetes would depend on if there are end organ damages or not. Starting ACE inhibitors and ARBs as the first line in a normoalbuminuric person, there is no added advantage when we compare CCBs with ACE ARBs in a normoalbuminuric patient. However, if there is evidence of moderately increased albuminuria or severely increased albuminuria, then obviously ACE ARBs are going to be the first line, and SGLT2s are going to be the second line in those cases, which are also going to, like Sir had discussed, it's going to also help with reducing systolic by 5 mm and diastolic by 2 mm. So it does have slight effect on it. And uske baad bhi, sir, if the hypertension is not controlled and there is still an albuminuria which is persistent even on maximum tolerated ACE/ARBs, then finerenone or spironolactone, which has now come back in vogue, is going to be my second line of drug.
Thank you, Dr. Setu. Dr. Pankaj, how will hypertension in CVA in patients with cerebrovascular accidents?
Right, so it's very important that not to decrease the blood pressure so rapidly, because in patient of cerebrovascular, say patient comes with hemorrhage, but the blood pressure is more than 220 by systolic and 120 by diastolic. So you have to gradually down the blood pressure, right? And in patient with comes with ischemic infarct also, right? Gradually, we have to take the blood pressure gradually, because sudden drop in blood pressure would be hazardous to those patients. So we should be very careful, maintain the blood pressure. And I think this ACE/ARBs are the good choices for those patients. And you have to gradually bring down the blood pressure, not very rapidly. This is my take home on that.
Dr. Neeru, please tell us how should we treat patients of hypertension in pregnancy?
In pregnancy, ACE-ARBs are contraindicated because they would reduce the placenta. Both the things, placental perfusion would be affected. Second, the vasoconstriction leads to poor growth of the fetus. So they are absolutely contraindicated. And any patient who has been on ACE or ARB should be switched to calcium channel blocker, that nifedipine, or this thing, labetalol, beta blocker. Labetalol is these two are the drug of choice. Amlodipine can also be used. Then methyl dopa used to be used in the past. This was alpha agonist, but nowadays it is not available. And if your patient has been on telmisartan, but it is not that you have to go for termination of pregnancy, but as soon as you get to know about it, you should stop it.
Same, ma'am. How will you treat patient of hypertension with CKD?
So in so it's the etiology that matters, whether patient has hyperkalemia or no hyperkalemia, patient has diabetes. It's a very etiology. Accordingly, you manage it. Normally, these patients, mostly we try with ACE inhibitors and ARBs. Calcium channel blockers are very good because most of patients are resistant hypertensions. So calcium channel blockers are frequently used, and it's all the antihypertensives that we normally use they are usually on 3, 4, or 5 drugs to control the blood pressure. But yes, it is a combination of hypertension. It's not that one drug being used at the highest doses. We usually prefer to give a combination of antihypertensives to control the blood pressure.
Madam, any view on this renal denervation? Because previously it was not useful, but now it's coming up again.
Renal denervation for resistant hypertension. Initially, it had come up, then it was said that it is not of much of use. But nowadays, it has again come in vogue. People are doing renal denervation for extremely high blood pressures.
Thank you, ma'am.
So we have drugs like diuretics and spironolactone or epinephrine, which can be used. And once the patient has if there is resistant hypertension, there is refractory hypertension. Then more than 5 drugs and still the blood pressure is not getting controlled. So in an expert situation, in a place who have an expertise, I think renal sympathetic denervation is a very good modality to bring down the blood pressure by 20 systolic and more than 10 diastolic. But unfortunately, in India, many of our centers are not doing it. We tried doing it once in Vax Vaishali, but we could not succeed. So we need more centers who are ready to do this. Now we have various ways by which you can do it. We have ultrasound ways. We have the other rays also which can be done. So maybe in future, once there is an expertise, then this will be employed very frequently.
Yes, sir.
Yes, sir.
Sir, Dr. Anand Pandey is there, then I can ask one question, a very relevant question to him. How to treat hypertension in patient with CAD and atrial fibrillation and congestive heart failure? The special conditions related to the cardiac illness, AF, congestive heart failure, and CAD. I think he is not there. Dr. Pankaj, can you enlighten us, please?
Yes, sir. Repeat the question, sir.
How to treat patients with hypertension, with AF, with congestive heart failure, and in patients who are having CAD.
Right, sir. So definitely the congestive heart failure, there are two categories: heart failure with reduced ejection and heart failure with preserved ejection. And now we have drugs now to treat otherly, and patients who are having heart failure with preserved ejection, I think this low dose diuretics would be helpful, along with ARBs and amlodipine. And in severe hypertension, definitely we can use high doses of loop diuretics and ACE and ARBs. Now ARNIs has been come up in a big way. The patients of hypertension with reduced ejection fraction, and they have the mortality benefit also. And we have not seen this mortality benefit with using diuretics, and but this ARNI has actually had the mortality benefit. Hypertension with atrial fibrillation definitely hypertension is a very good risk factor for atrial fibrillation, and we have to look for the Chadwick scores, and specifically we can use patients on this VK also, because atrial fibrillation is a risk factor for the thromboembolic blood from us. So we have to very aware of that. We should these patients should be on some this anticoagulants as well as far as the blood pressure is going down.
Thank you, Dr. Pankaj. And we have the last slides. What are the hypertensive complications, especially in the eyes? Dr. Pankaj, you continue, please.
What's that? What questions are?
The complications of hypertension.
Yes, sir. The complications of hypertension, definitely, if you look into the overall global phenomenon, this hypertensive heart disease is actually very common, and we do see left ventricular hypertrophy, vascular dysfunction in our patients, cerebral vascular disease, CVAs, acute MIs, renal dysfunction, acute renal failures. Then we have retinopathies, acute retinopathies. We have large vascular disease, peripheral artery disease. So there are a lot of end complications, and we are talking about this edge moderate hypertensive target organ disease. And if the cornerstone is control of blood pressure, the borderline is if you control blood pressure, you can actually allay all these complications of this disease with high mortality. And that's why we are just observing this hypertension day, so that sooner if we control the blood pressure, we can actually reduce the complications, sir.
Thank you very much, Pankaj, for completing the talk with complications of hypertension. And I am thankful and very grateful to our worthy Professor N.P. Singh, Dr. Neeru Agrawal, Dr. Anand Pandey, Dr. Setu Gupta for their valuable time. They have taken their really 1.5 hours of their valuable time and for EDPA. And thank you on behalf of EDPA. And thanks all the participants, all the delegates who are there and spared their time. And this program was for the awareness of hypertension on Hypertension Day. And thank you very much, everybody.
And Vijay, you have led the field very well, and your questions were very crisp, and also you were able to take everyone together. And
Yes, sir.
compliments to Pankaj also for allowing us to attend these meetings through online mode. And I enjoyed attending as well as participating in these meetings. Thank you very much for
Always a
inviting me.
motivating force.
Thank you.
So, sir, we are actually honored to invite you all for nephrology update, which is going to be held on 20th of July, and definitely we'll have much knowledge that can be there with the able chairmanship of Dr. U.P. Agrawal. And ma'am, we have started working on that, and definitely we would be meeting soon for finalize the program. And Swati, I think for formal thanks to everyone, and few of us are still left. So I congratulate Dr. Vijay Arora sir for a very nice, and I knew that Dr. Vijay Arora is making a very good having a very great in parent discussion, and we have seen in LeadCon and other conferences now. So I think we have a very able chairman of scientific committee, sir. Dr. Swati, over to you.
Yes, sir. I want to second you here. I think we are really thankful to Dr. Vijay Arora for being the chairman scientific committee. I think he'll take EDPA academics a notch above. And we are really thankful to Dr. N.P. Singh sir for joining us from US again and again. Even for the CPC, sir took a lot of effort in joining. And again today, thank you, Dr. Neeru ma'am and Dr. Setu for all your expert inputs.
Very good night to everybody, and definitely we'll meet sometime again.
And we need further suggestion to improve our presentations and topics. Thank you very much.
Thank you, sir. Good night. Good night. Shambhu, we can come to the meeting now.